pharmacies across the country. In America today, if you receive a cancer diagnosis, chances are scientists and doctors have developed effective treatments to fight or beat this horrible disease. While most of the spotlight tends to fall on new, cutting-edge innovations, some of the most vital treatments for millions of Americans suffering from cancer and other chronic illnesses are lower-cost generic medicines that can really help and have been around for many years. These are the products where the shortages are felt the most, and it threatens the health and well-being of the country. Earlier this year, the Finance Committee began to investigate what was causing a widespread shortage of ADHD medications in Oregon and across the country. What we found was shocking. The supply chains for these prescriptions that millions of Americans count on to work and learn were bogged down in what can only be called bureaucratic bedlam. Manufacturers, the DEA, and the Food and Drug Administration all offered conflicting explanations for why the shortages for Adderall and its generics have persisted and why patients have been in the dark without clear answers. So we are now pushing to resolve these shortages and add transparency and flexibility so it doesn't happen again. So today, the Finance Committee is going to examine the causes of these devastating drug shortages. In particular, the committee is going to look to use the power of Medicare and Medicaid, which covers millions of Americans and pays for hundreds of billions of dollars in health care spending every year. This is urgent business for this committee, and it's going to be key to find bipartisan solutions that are going to get at the persistent and tragic problem. The consequences of these drug shortages are not abstract. I have town hall meetings in all of my counties each year, and at all of these meetings, I'm hearing about the problems of the shortages at pharmacies in Oregon across the state, and this has hit rural communities in rural America like a wrecking ball. There's been story after story of drug shortages resulting in rationing, inappropriately low doses, or alternative treatments that aren't as safe and effective as the product that's experiencing the shortage. These shortages can be life or death for kids, especially when it comes to the cancer drugs. The evidence shows that the cause of the vast majority of drug shortages is, in effect, a set of market failures. Right now, they exist across the prescription drug supply chain, from manufacturers to providers, as well as the middlemen that we, of course, know here, the PBMs and drug wholesalers. A substantial portion of the market failures are driven by the consolidation of generic drug purchasing among a small group of very powerful healthcare middlemen. There are many companies that manufacture generics, but they must compete for the attention of highly consolidated middlemen, such as the drug wholesalers and hospital group purchasing organizations, to gain access to markets. In the case of drug wholesalers, 3 companies control 90% of the pharmaceutical market in the country, and all 3 of those companies are among the top 15 largest businesses in America by revenue. The generic manufacturers that are awarded contracts by these middlemen do so by offering penny-on-the-dollar prices that mean they can't invest in the capacity or equipment that is the key to actually making reliable, high-quality medications. So you have, in effect, a race-to-the-bottom price war for generics that leads to quality control problems and factory shutdowns, which leads to a shortage of generic drug products that, of course, are in high demand. So we are in a position on the Finance Committee to correct this mess. Senator Crapo and I work often on these issues, particularly where we're dealing with issues that involve Medicare Part A and Part B. B in particular, paying for services in doctors' offices, hospitals, Part A, including prescription drugs that are administered there, like chemotherapy treatments and related injectable drugs. Some of the injectables are facing the most serious shortages. In Part D, 90% of the medications dispensed are generics. As the committee has found as we worked on the pharmaceutical benefit manager issue, Even if manufacturers are selling generics at low prices, the middlemen have free rein to mark up prices along the way. And once again, the circle comes back with seniors getting higher costs in America. While middlemen get rich and consumers pay more than they ought to for generics, manufacturers may decide it's not worth the trouble to even produce the medicines and just get out of the market. So those are some of the issues that we have to tackle. Suffice it to say, not all of these issues relating to market failures will come up in coffee shops across America every morning, but we sure know that a lot of people are hurting and they're talking about what's going to be done about this. And we have a chance to work in a bipartisan way as we've done on healthcare issues so often. And I want to recognize my friend, Senator Crapo.
Thank you, Mr. Chairman. This year, the Finance Committee has taken unparalleled action on prescription drug access and affordability. Our bipartisan PBM reform legislation would cut patient costs at the pharmacy counter, strengthen provider choice for seniors across the country, and reverse warped incentives that currently favor higher-priced medications. Our policies would accomplish all of this and more while reducing the federal deficit. Taxpayers, consumers, and community pharmacies deserve to see these bills passed by the full Congress and delivered to the President's desk as quickly as possible. For patients with chronic conditions, as well as independent pharmacies at risk of potential closure, inaction is not an option. As our PBM process has shown, bipartisan, consensus-based, and market-driven policymaking can address a wide range of challenges facing seniors and working families. In that same spirit of exploring effective legislative solutions, today we turn to another issue harming the health and finances of Americans in every state: the surge in drug shortages. For treatments targeting any number of conditions, from pediatric cancer to mental health ailments, our ability to prevent and resolve shortages can mean the difference between life and death. To develop meaningful policy improvements to reverse the current rise in drug shortages, however, we first need to understand and examine the economic drivers, with a focus on federal programs within our committee's jurisdiction. While high-priced medications have received outsized attention during prescription drug discussions in Congress, shortages disproportionately affect low-cost therapeutics, which operate in a largely different and increasingly challenging economic environment. In fact, 84% of shortages occur in generic drugs, and 56% of products in shortages have unit prices below $1. Given that generics comprise roughly 9 in every 10 prescriptions filled across the United States, these shortages can inflict drastic harm on massive populations of Americans. The average shortage affects at least 500,000 consumers, forcing them to scramble for viable alternatives or else forego treatment entirely. As experts and officials have broadly affirmed, the structure of the generic market incentivizes a proverbial race to the bottom on pricing. Since 2016, generics have seen price erosion in excess of 50%. The razor-thin margins resulting from these dynamics trigger a host of dire consequences, from discouraging quality investments to spurring widespread outsourcing, including to China. Moreover, the generic drug maker exit rate currently exceeds the rate of entry, and upwards of 40% of generic medication markets are supplied by a single manufacturer. Rather than reduce shortage risks, unfortunately, a number of government policies make them even more pervasive and worse. Medicaid's inflation-based rebates, for instance, can trigger massive uncapped losses on even low-cost generics, in addition to requiring literal penny pricing under 340B. These and other price control policies warrant serious scrutiny in the context of generic products, especially for sterile injectables, which carry high production costs and offer minimal return. More broadly, our reimbursement systems, including under Medicare, offer little opportunity or incentive for drug makers to compete on dimensions other than price, such as reliability and resiliency. The House Energy and Commerce Committee's comprehensive work on this issue thus far is welcome. Enacting effective legislation will necessitate bipartisan and bicameral collaboration. The Finance Committee can build on our strong track record of solutions-oriented policymaking to address the rash of drug shortages afflicting families across the country. Mr. Chairman, before I conclude, I'd like to ask unanimous consent to enter a statement from the Community Oncology Alliance into the record.
Without objection, so ordered.
This statement highlights the grave risks posed by shortages for those seeking cancer care. With that, thank you to our witnesses for being here today, and thank you, Mr. Chairman.
I thank my colleague, and I think this is another issue, along with the work we've been doing on the PBMs and other matters, that is ripe for a bipartisan effort, and this would respond to both patients and taxpayers, and I look forward to working with all my colleagues on it. We've got an excellent panel, sort of the NBA all-stars of the field, so to speak. Dr. Hernandez, Dr. Inmu Hernandez is a pharmaceutical health services researcher and a professor at the University of California at San Diego. Her research focuses on improving medication uses, outcomes, and equity. We welcome you. Next to you is Dr. Marta Wosinska, a senior fellow with the Schaefer Initiative in Health Policy at the Brookings Institute. She's a health economist, specializes in the question of markets, obviously the topic today, and has worked at the FDA, the Federal Trade Commission, and the Department of Health and Human Services. Then we have Mr. Alan Cockel, Vice President for Public Policy with Civica RX, President of the Civica Foundation. He started his career as a clinical pharmacist in the field. And then we have Jason Weston, Professor of Medicine in the Department of Lymphoma and Myeloma at the University of Texas MD Anderson, and he is Director of Lymphoma Clinical Research there at the center. So we've got an excellent panel. Let's begin with you, Dr. Hernandez. And I know everybody always feels sort of compelled to read every word in their statement. We'll make your statements part of the hearing record in their entirety, and you can just take your 5 minutes or so and tell us what's important to you. Doctor.
Chairman Wyden, Ranking Member Kripo, and honorable members of the committee, thank you for the invitation to testify today. My name is Inmaculada Hernandez, and I'm a pharmacist by training and a professor at the University of California in San Diego. Mr. Chairman, I applaud you for holding this hearing. Drug shortages are a significant public health risk of the highest national priority. This year, doctors were forced to ration the use of cancer drugs due to a shortage. This shortage is only one of hundreds that threaten patient access to life-saving medications. In the US, drug shortages disproportionately affect low-cost generic products. There are many underlying factors contributing to shortages, but the primary drivers are economic and regulatory. My testimony will focus on economic drivers and offer potential solutions. Generic drugs are equivalent versions of the same product manufactured by different companies. Generally, the pharmacy or the provider can choose any manufacturer's version. The reimbursement paid to the pharmacy or the provider is the same regardless of the generic version selected. As a result, pharmacies and providers are incentivized to purchase generic versions with the lowest acquisition cost. In other words, pharmacies and providers have no incentive to purchase drugs from manufacturers that have more resilient and dependable supply chains. These reimbursement practices have been crucial to keep costs down in Medicare and Medicaid. However, they have eroded prices and in some cases threaten market sustainability. Manufacturers lack incentives to invest in dependable supply chains. This is particularly the case for products with limited profitability, such as older but essential generic injectables. They are expensive to manufacture and their prices have sunk after decades of competition. Manufacturers respond to decreased profit margins by engaging in cost containment strategies. These include reduced factory maintenance, for example, but also offshoring. Most generic drugs used in the United States are manufactured overseas, primarily in India and China. Cost containment strategies, including offshoring, increase the risk of quality issues. Manufacturers in India and China receive the most FDA warnings for violations of good manufacturing practices. Quality issues generate shortages because production must be halted until issues are resolved. In light of these challenges, manufacturers may decide to discontinue the production of less profitable drugs. This contributes to market concentration and limits the ability to respond to supply disruptions. In summary, we have a drug supply chain that heavily relies on foreign manufacturing. This is a national public health risk. We also have a reimbursement system that fails to reward manufacturers to invest in dependable supply chains. In some cases, profit margins are so low that manufacturers simply don't have incentives to produce the drug at all. Policy intervention is urgently needed to address these issues. Short term, the federal government should consider funding the reshoring of generic manufacturing. Funding should be tied to supply guarantees and resilience of the supply chain. In addition, we need to build incentives for pharmacies and providers to purchase drugs from manufacturers with dependable supply chains. This could be achieved through the incorporation of value-based payments, meaning that payments to pharmacies and providers would be higher when they select generics from more dependable supply chains. Admittedly, these solutions will likely result in increased government spending. This spending is a necessary investment. Without intervention, drug shortages will continue to threaten patient access to life-saving medications. Just as we invest in building roads and bridges and manufacturing semiconductors, we must invest in generic drugs. It is critical to further our country's health and to protect national security. Thank you for your attention.
Thank you very much, Dr. Hernandez. There was a little huddle here because we all think your testimony is so impressive, and we're trying to figure out the next steps. So we thank you. Dr. Sinska, please, your testimony.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for inviting me here today. My name is Marta Wosińska, and I'm an economist and a senior fellow in economic studies at the Brookings Institution. I have been studying drug shortages for over a decade. Much of my work deals actually with economic incentives that contribute to drug shortages. In the follow-on conversation, I'll be able to speak to drug shortages more broadly, but in my remarks, I would like to discuss why low-cost generic sterile injectable drugs are so vulnerable to shortages and why this committee is well-positioned to address these shortages. Generic sterile injectable drugs, or what I call GSI drugs, include drugs to treat cancer, crash cart drugs used to treat life-threatening emergencies, morphine, IV antibiotics and IV nutrition, and something as basic as saline and sterile water for injection. GSI drugs are, and have been for years, the most common type of drugs to be in shortage. Typically, these drugs represent about half to two-thirds of all shortages. GSI shortages result primarily from manufacturing quality problems at facilities where the final product is made, often in the United States. The resulting shortages generally last months, and more increasingly, several years. What is vexing about these shortages is that they're largely avoidable. Most of these shortages do not result from external shocks like pandemics or natural disasters, but instead from factors that drive how hospitals buy GSI drugs and the underinvestment in manufacturing operations that follows. So what are the factors driving which GSI drugs hospitals buy? All payers, including CMS, reimburse hospitals in a way that gives them incentives to use the lowest priced GSI drug available. These reimbursement mechanisms have a point. After all, two generic versions of the same drug are therapeutically equivalent and therefore readily substitutable. But therapeutic equivalence is not the same as reliability of supply. The price pressures put on manufacturers create a dynamic where there's little room for or little return on investing in manufacturing facilities, staffing, and oversight. These price pressures are particularly consequential for GSI drugs because making those drugs required specialized facilities where employees follow complex manufacturing processes and controls. There's simply less room for error in manufacturing because GSI drugs must be sterile and free of contamination of particulates. As the largest single payer for hospital stays and outpatient visits in the US, CMS is well positioned to influence how hospitals buy. If we want to address the persistent GSI drug shortages, CMS will need to pay hospitals differently, incentivizing them to consider reliability of supply in their purchasing decisions. This can and should be done by rewarding hospitals for buying reliably and for buffering before shortages happen. In my written testimony, I describe in detail how such a program could be stood up. Here, I will only mention that the proposed program builds on and boosts on existing tools to assess reliability and efforts to reward supply chain reliability, such as the one that the next witness will discuss. The program leverages the private sector's ingenuity in developing new tools and creating new contracting models. And the program goes beyond rewarding manufacturing quality. It also rewards to protect from other sorts of problems like natural disasters and geopolitical instability. The program also accounts for the differences in the economic environments that different hospitals face, which is really important. And last but not least, the program can be stood up now without having to wait for FDA to develop a set of quality metrics. But CMS does not have the authority to set up such a program, especially one that is not budget neutral. This committee, however, can grant that authority. To conclude, I would like to say that this is not the first time we have had cancer drug shortages, and it will not be the last unless Congress steps in to support CMS's role in this space. Getting at the issue through CMS is critical because CMS is much better positioned than FDA to address economics. For this reason, I would like to, again, thank Chairman Wyden and Ranking Member Crapo for holding a hearing on this issue. I hope you'll consider the recommendations I provided in my testimony, and I look forward to answering your questions.
Thank you very much. Mr. Kakel.
Chairman Wyden, Ranking Member Crapo, and members of the committee, thank you for holding this important hearing on the pressing issue of drug shortages. My name is Alan Cockle. I'm a pharmacist by training, and I lead public policy for Civica, also known as Civica RX. Civica is the only pharmaceutical company established especially to address drug shortages. It was founded by a group of U.S. health systems and philanthropies who, after a decade of shortages, realized that the market is not self-correcting and that a different approach is required. They created Civica as a nonprofit with a mission to deliver a safe, stable, and affordable supply of essential medicines to U.S. patients. In our first 5 years of operation, our hospital membership has grown to 1,500 hospitals. We have 80 drugs now with nearly 150 million vials delivered. And with U.S. government support, we've built a state-of-the-art injectable drug manufacturing facility in Petersburg, Virginia. Civica drugs are not chosen for their return on investment. They are chosen by hospitals because they're in shortage or at risk of being in shortage. They tend to be old and low cost, but absolutely essential and used in every hospital every day to treat patients. Because of our mission, Civica does some things differently from the traditional generic drug supply chain. For example, we enter long-term purchase and supply contracts that add stability to the market. We maintain a 6-month buffer inventory of every drug to ensure continuity of supply. We also emphasize U.S. sourcing whenever possible, with the EU and Canada as our next choice, and we don't source from China unless there's no other option. To reduce the risk of a failure to supply, we perform an intensive quality audit of potential suppliers and ongoing quality reviews. And every drug is sold at the same price to any purchaser. The success of the approach has been proven. In fact, 20 of our top 25 products are currently in national shortage, and yet we're supplying member hospitals without interruption. When a tornado hit a generic drug manufacturing plant in North Carolina a few months ago, we immediately let our member hospitals know that of the 21 drugs we have that overlap with drugs from that facility, we would be able to supply double their committed volume. And a recent peer-reviewed study found that supply through Civica is not only more reliable than conventional sources, it also produced net cost savings. So the resilience of this model points to steps that this committee could take to prevent future drug shortages. And make no mistake, shortages are not a passing storm that will soon blow over. After a dozen years, they must now be understood as a built-in and permanent outcome of our current system. The U.S. system is designed so that purchasers of drugs are incentivized to choose the lowest price, saving pennies on already low-cost products, instead of purchasing in a way that makes shortages less likely. Civica's member hospitals have already taken steps to shift the equation, but many others have not, and without action, things will get worse. The immediate cause of most shortages is quality problems in the manufacture of the finished dosage form. But the root cause, as we've said, is low prices. And to put that in perspective, a vial of sterile injectable medicine typically costs less than this cup of coffee that I bought downstairs this morning. So this reduces the incentive of manufacturers to invest in quality or in newer manufacturing facilities. And low prices push production offshore to low-wage markets where quality problems proliferate and the FDA presence is less consistent. Finally, it takes time to ramp up pharmaceutical production. So when one manufacturer leaves the market, we're facing a shortage, even if there are other manufacturers that already have FDA approval to make that drug. So policy responses to reduce shortages should include measures to incentivize or encourage providers to contract for adequate buffer inventory, purchase from manufacturers that are less likely to have quality failures, and enter long-term contracts that bring stability to the market. We also encourage Congress to work directly with manufacturers to create an insurance policy. For the cost of about $4 million a drug, Congress can ensure that we have backup domestic manufacturing capacity ready to go when a shortage starts. And how smart would we feel today if 5 years ago we'd made this investment in cancer drugs and we were prepared for the shortages we're experiencing now? A timely investment will provide a cost-effective insurance policy for the future. Thank you again for your attention to this topic and for the opportunity to be here, and I look forward to your questions.
Thank you very much. Mr. Weston.
Chairman Wyden, Ranking Member Crapo, and members of the committee, it's my pleasure to appear before you to discuss the drug shortage crisis facing our patients. I'm Dr. Jason Weston, Professor of Medicine, Director of Lymphoma Clinical Research at MD Anderson Cancer Center in Houston, Texas. Today, I'm speaking on behalf of the Association for Clinical Oncology, or ASCO, the leading oncology professional organization representing nearly 50,000 oncology professionals dedicated to improving cancer care. We deeply appreciate the committee's bipartisan dedication to addressing the root causes of drug shortages. I aim to provide a firsthand account of the challenges faced by cancer patients and their healthcare providers from oncology drug shortages. This crisis impacts whether patients receive life-saving and life-prolonging oncology drugs as intended or are forced to receive suboptimal alternatives, reduced doses, delayed treatments, or worse, not receiving our best therapies. Many of my colleagues have been forced to make impossible choices, including to choose which patients will be prioritized to receive potentially curative therapy. When physicians must use treatments that may not be standard of care, prior authorization, already an untenable burden, becomes even more intrusive. Patients and their families look to us as a trusted source, and we're left with no explanation. In 2022, I encountered a shortage of a drug called fludarabine, a cheap and generic drug initially approved over 30 years ago. Fludarabine isn't the most common drug anymore, but it is an essential component of CAR T-cell therapy, an almost science fiction-like technology that weaponizes a patient's own immune cells to fight their cancer and hopefully eliminate their cancer, which can sometimes cure patients of otherwise fatal cancers. The effectiveness of CAR T-cell therapy, however, is dependent upon being given with fludarabine, and unfortunately there are no proven alternatives. My patients with rapidly progressing relapsed aggressive blood cancers usually only get one shot at CAR T-cell treatment because they may be too sick to try again. And with shortages, I don't know if CAR T-cell will work without fludarabine, and I can't wait to try when fludarabine's back in stock. In other words, the absence of a generic and cheap drug like fludarabine literally can be the difference between life and death. I recently treated a young mother of 3 with cancer that grew despite multiple lines of treatment. Contemplating hospice care, she received CAR T-cell therapy and now is in a long-term remission, offering her the potential for decades of life and her children the security of having their mom alive and well. Her story and countless others like it would not be possible without drugs impacted by these shortages. We know how to treat cancer, but shortages force impossible choices. We have drugs that are life-saving and shortages that are life-threatening. The U.S. needs a more robust drug supply chain to avert future shortages of key medications. Most oncology drugs in shortage are older generic injectables that typically experience slim or sometimes negative profit margins. The leading cause of shortages is manufacturing quality issues, and correcting these can be expensive, leaving manufacturers shuttered for months or deciding to leave the market altogether. Quality issues in one company can impact and have a domino effect on the entire supply chain. Current drug payment policies can compound quality issues as purchasers have limited information, typically only price data, and do not have access or quality to quality or supply information. This creates incentives for manufacturers to prioritize cost-cutting over quality improvements. The current Medicare's payment system bases drug reimbursement on average sales price plus 6%, which may result in artificially low reimbursement because of delays in updating ASP. This creates barriers for new manufacturers to enter, for production increases, and for correcting quality issues. Congress should consider alternative payment methodologies that would provide immediate relief from artificially low rates and encourage a more reliable supply of drugs. CMS is constrained in how it pays for drugs, but it could use demonstration projects to set a reimbursement floor on shortage-prone critical drugs, could investigate tying increased reimbursement to guaranteed supply, or could leverage the FDA's pilot program, which promotes quality manufacturing and reliable drug supply. There are existing examples of purchasers that were willing to pay increased prices for return and guaranteed supply. Policymakers could incentivize drug supply chain changes by promoting advanced manufacturing technology and continuous manufacturing for critical drugs, by considering coupling enforcement mechanisms to existing risk management requirements, and by incentivizing purchasers to favor manufacturing with reliable supply. HHS could incentivize private sector reserve of essential medications, medical devices, and supplies. These proposals should be implemented in a manner that avoids hoarding or creates additional shortages or supply chain challenges, and includes consideration of the unique need of independent and private practices. We recognize concerns around increased cost, but we will pay a greater long-term cost in the form of delayed or denied care if we do not address underlying economic forces driving shortages of generic drugs. In conclusion, we at ASCO applaud the committee's efforts to enhance the pharmaceutical and medical supply chain to protect our nation's most vulnerable patients. The shortage of critical cancer drugs is an urgent crisis, and we stand ready to collaborate with you to advance comprehensive solutions that ensure Americans with cancer receive life-saving and life-prolonging treatments, and to help end these life-threatening shortages. Providers shouldn't have to make impossible choices about patient care. Thank you. I look forward to your questions.
Thank you very much, and all of you have been excellent. And let me start with you, if I could, Mr. Cockle. I mean, you tell an incredibly important story. You talk about how somehow you're able to get help to people even in this whole bedlam, as I described, of shortages, and yet your membership, your hospitals, you've been able to continue to meet their needs. I think I'd be interested in your thoughts if we were to, and we're going to work on this in a bipartisan way, so we're going to try and get as many ideas as we can out there. If we decided to direct Medicare to pay separately for sterile injectables, do you think that would give us a chance to get those twin objectives, as not just price, but quality?
Thank you, Senator. Appreciate that question. I think potentially, and it would depend on how it was constructed. If the payment increased the provider reimbursement, but didn't change the incentive to buy below the reimbursement level, then you'd have the effect of increasing the spread or the margin without really shifting the purchasing patterns that are driving shortages in the first place. But if that reimbursement that you were talking about was tied to some of the shifts that many of the witnesses have talked about today in terms of laying in extra inventory and selecting manufacturers that are less likely to have a shortage, you could see it having exactly the desired effect.
Good. Dr. Hernandez, you basically, in a very impressive presentation, I gather you're coming out today with a analysis that'll be in the Journal of American Medicine. Is that correct? So we can talk about that and what you've shown about price gouging and the like. But you believe, according to your testimony, you want to tie a lot of the reforms to value-based purchasing, which strikes me as an appealing idea. Can you give us a little bit more detail about how we might go about, doing that? I know that time is short and we can't get into lots and lots of information, but I'd just be interested in a little bit more information about your theory of tying this to value-based purchasing.
So I think the idea could be to tie the reimbursement to the provider on the quality and the resilience of the supply chain of the manufacturer selected. Meaning, right now we are paying an average sales price. The average sales price is a weighted average of all generic and branded versions for a product, right? Providers are incentivized to buy at the lowest acquisition cost. But maybe you could still pay based on average sales price, but do something like average sales price plus 20% if you use the injectable drug manufactured from a provider, from a manufacturer that has 5 out of 5 stars in resiliency of the supply chain. That would need separate reimbursement because most generic injectable drugs, which are, as we heard, most prone to shortages, are reimbursed under Medicare Part A, and in some cases under Part B, but in Part A, they are not paid separately, meaning that the hospital gets a bundle payment for all of the services provided under a hospitalization. If we want to pay more for drugs that were manufactured from resilient supply chains, we also need to apply that modifier to a drug claim level that I think would probably need separate reimbursement. So it's pretty much in line with what Mr. Kukel said. I think separate reimbursement would work, and we could attach to that like a value-based modifier, meaning a percent increase based on how resilient the supply chain is of the generic version selected.
So let me just use the rest of my time on this question of the price gouging and the middlemen markups on generics, and we'll just throw this open to any panel member. The Wall Street Journal recently reported that PBMs mark up prices of generic medicines by hundreds, sometimes several thousand% higher than the price paid to the pharmacy. The markups jack up costs, leaving taxpayers to foot the bill, don't do anything to help prevent drug shortages. I'd be interested in what this panel thinks you ought to be doing as part of our efforts here to rein in this price gouging by middlemen, specifically on generics. And I gather that Dr. Hernandez's study is going to come out today, be peer-reviewed, be more extensive. So I think we know what the problem is. Why don't we get Dr. Wosinska? I know that you're an expert in this field and have background in government. Why don't we start with you? But I'd be interested in what the four of you think for my last question we ought to be doing with respect to price gouging here. Doctor.
So price gouging in the context of drug shortages perhaps maybe happens more with the gray market when the drug is in shortage and then hospitals are really desperate and trying to get product in hand. So I think if we were to tie this here, but perhaps I could speak to the role of PBMs in this sort of dynamic and price pressure more broadly. So PBMs are vertically integrated with mail pharmacies and also with specialty pharmacies. And so just like all pharmacies, they also, just like hospitals, try to buy the least expensive, therapeutically equivalent product possible. So in a sense, through the pharmacy channel, they are very much contributing to the downward price pressure. They don't really play in the generic sterile injectable space, but they very much contribute to the sort of price pressures in the oral dose products. And there again, there's sort of no mechanism. There is no weight put in place really on reliability of supply.
Let me just, because I'm over my time, Dr. Hernandez, your thoughts on that? What's going on here in the generic market? What can be done to rein in the middlemen?
I apologize for interrupting you, Mr. Chairman. Let me just briefly summarize the findings of the paper so that everyone is on the same page. So we just look at reimbursement rates paid by the 6 leading party organizations in Medicare Part D for the top 50 generic drugs by Medicare spending. We found 16 drugs reimbursed by at least one party organization at a markup of 1,000% or higher, okay? For instance, I have here an example for you. Aripiprazole is an antipsychotic drug. The pharmacies paid an average of 17 cents per tablet. Rite Aid, and when I say Rite Aid, I mean the PBM, not the pharmacy chain, because Rite Aid is also a PBM that offers party plans. Okay, so Rite Aid paid pharmacies $11.7 per tablet. Again, the price was less than 17 cents. So we're talking here about a 7,000% markup. Cigna reimbursed pharmacies at $4.6 per tablet or at $2,700 markup. CVS Health reimbursement rates were very similar, so we're not just talking here about rate 8 PBM. These practices are concerning because if patients, let's say, had a 30% cost-sharing on their aripiprazole, they could pay 30% of the inflated amount. So they end up paying much more than actually the pharmacy paid for the drug, let alone the manufacturer got for it. So in summary, I think the way how we pay for generics needs reform because on one hand, we are failing to incentivize manufacturers to invest in resilient supply chains. On the other hand, in the Part D side, we are allowing intermediaries, and by intermediaries I mean PBMs, to inflate the costs of drugs without justification, which ends up in seniors paying more. I truly appreciate the efforts, and I applaud the efforts of the committee to look at PBMs earlier this year. And I think the legislation that you put together has a major impact for making a difference.
We'll be able to ask you more in the future, and you've been helpful. Thank you. Senator Crapo.
Thank you very much, Mr. Chairman. And again, thank you to all our witnesses for the expertise you bring to us today. And let me tell you the issue that I'm focused on. Every one of you has made the point that one of the big problems here is that we don't compensate for quality of product. We compensate for price of product only. And I get that. What I'm trying to figure out, given the fact that we are talking about federal government administrated payment systems, is who's going to decide, if we get a solution here, who decides which products are worth more compensation? Dr. Hernandez, you said that maybe there should be a 20% markup compensated by us for those that got 4 stars. Who decides who gets 4 stars? Do we want to have a federal government agency evaluate every generic provider and decide? I personally have a little bit of trouble with that. The hospital or the doctor who is providing or subscribing or prescribing the medicine should be making that decision, but they're going to choose the one that they get the compensation for in a system where the government is paying the compensation. How do we incentivize the doctors or the hospitals to make the proper choice and not have the federal agency be the one, not create a federal quality of generics agency at the federal level? I hope you understand my question. And you raised your hand, Dr. Rosinska. Why don't you go ahead, and then Dr. Cockle, and well, anybody can jump in.
Yeah, I would love to speak to this. So there have been a number of proposals, and actually if you look at the proposal that I put out earlier this year, I would like FDA to continue with the steps that they have been that they have been taking to develop metrics to ascertain whether a facility is following good manufacturing practices and quality maturity. But that to really expect that FDA is going to be able to do it for all drugs would require incredible resources and many years. Even if we were to zero in on just generic sterile injectables, at this point, we probably would be waiting several years, and we still don't know whether the program they would stand up and the metrics they would stand up would do exactly what we want them to do. So the reason why my proposal is somewhat different is I do think that those kinds of metrics could be built in, but I very much believe that a pay-for-performance program for hospitals, rather than an add-on or a payment, sort of looking at a payment adjustment, is the way to go. You can basically ask hospitals to look back at the end of the year. There are usually 30, 40 shortages each year. And at the end of the year, you basically ask them, how did you do in terms of preparing for these shortages? They don't know which shortages, but the idea is to sort of have them be thinking about which suppliers are more reliable and be thinking of sort of who did you buy from? Did you buy from Intas, which caused the shortage of cancer drugs, or did you buy from Fresenius Kabi? And there is enough information out there already that hospitals, actually not hospitals, I actually should say, I don't expect hospitals to be doing the homework. Their GPOs are currently doing a lot of that homework, but they're not incentivized to use that because hospitals still want to buy the cheapest. So there are a lot of elements in place. Civica, for example, Civica's program would do really well in this case. And so the idea is to look back and then score the hospitals. Did you pick right? Where you buffer your inventory before there was any sign of shortage? It would really drive the development of tools, and it would allow, and then basically the idea is to have compare hospitals, just like with value-based payment program. Compare hospitals, you look at Mayo Clinic and Intermountain, who did much better here, and then there would be a payment adjustment at the end of the year where CMS would basically reward the ones that are doing better.
All right. Dr.
And you
Conkle?
don't need FDA metrics to stand that up. We can stand it up now.
Let me make a couple of points. One, we don't have to shift 100% of the market. We just need some big chunk of the market to shift towards more reliable supply to give us that resiliency and redundancy that we need. And number two, most purchasing is not done by individual small hospitals. It's done by big organizations on behalf of hundreds of hospitals. So these are sophisticated organizations that can do it. Civica is a small company, but we have a process for qualifying and validating our suppliers. It would be useful if the FDA's quality metrics program were out and ready, but even absent that, if we create the market, create the incentive for the private sector to choose quality, then I think various private sector solutions will emerge to evaluate the quality of different manufacturers and make that choice.
Thank you. I see my time's up. I'd encourage both of the witnesses who didn't get a chance to address that to please send us any written response to that if you feel you have something to add. Thank you.
Thank you, Senator Crapo. This whole question of pay for performance, we can look forward, we can look backward, but we need more information on it. So I share Senator Crapo's view. Senator Stabenow.
Well, thank you, Mr. Chairman and Ranking Member, and thank you to all of you. And I appreciate what Civica is doing right now in looking, at how we tackle this. This is such a complicated issue. It's not just in what's happening in supply chains and so on, but price. And if you step back and look at the whole thing, it starts with taxpayers of this country giving hundreds of billions of dollars to drug companies for basic research. We fund the basic research in our country for whatever is done in prescription drugs and so on. And then we allow write-offs for additional efforts in terms of putting together commercialization and so on. And then we have a situation where, in the interest of cheaper costs, those companies then go to India or China to be able to produce these drugs. There's something wrong with this picture on multiple levels, as well as just how do we incentivize. I mean, I think from a big picture, this is, there's a public interest because this is medicine. It's about curing cancer. It's about making sure medicine's available. So there is a public role, which means there is a role federally for us. And we took a piece of that. I mean, we did a piece of that last year in saying insulin, that $10 to produce hundreds of dollars for someone to actually get it who's a diabetic. And we capped it for someone on Medicare at $35 a month in the public interest to help people get life-saving drugs that, frankly, was over 100 years old. And so we did that. We have looked at other pieces on the pricing side, but we know it's not enough. If it's affordable, it's got to be available. And that's what today's about, is it available? And so I very much appreciate, let me say first, that the Biden administration is looking at supply chains and has taken, as it relates to drug shortages, taken action through the Defense Production Act. That's one of the ways we have to be able to do that, which is important. And in addition to that, essential medications, investing in, including $35 million to produce key materials for sterile injectable drugs, again, I think in the public interest. And we all know, we've been talking about today how important those medications are, and they are putting together, they are focused on a supply chain resiliency and shortage program with a coordinator and so on. So all of this so very important, all of these pieces, and it is complicated. I mean, we certainly want to incentivize the right thing. I'm not interested in just giving more dollars to the drug companies who are already pricing folks out of their ability to get their medicine, but I do think within the system, we need to be providing incentives and so on. Dr. Hernandez, I wanted just to ask you, back when we did the Affordable Care Act, there was language I put in there based on work being done at the University of Michigan on value-based purchasing, actually is in the ACA. I don't know if you have looked at that or there any way to use that kind of language even on what you're talking about, because value does matter. It's not just the cheapest medicine. Anybody getting health care would say, just give me the cheapest, give me you want the best in terms of value and so on. But we did make some steps to try to, signal that, and I don't know if you've looked at all at that language.
I think we may have done in other sectors of healthcare, but not precisely on purchasing of generic drugs, which is where we have shortages. So I agree. I think we need to maybe apply that philosophy of paying for value that I agree has been very well developed at the University of Michigan by good colleagues of me. So I think we need to apply that to the purchasing of generic drugs.
Great. Thank you very much. And let me ask, on supply chains and improving quality, Dr. Wyden, let me ask, you talked about the shortages being caused by manufacturing quality problems. Can you talk a little bit more about what investments drug manufacturers could make to prevent frequent quality issues? Talk a little bit more about that.
So that's challenging. I mean, I can make a very long list of the things that they could do. They just don't have an incentive to do it, right? So that's where the struggle is. If you look at where drug shortages tend to happen, the reason why it's generics versus brands. So I should say branded drugs do go into shortage sometimes too, but actually frequently because they have a really unexpected dynamic, such as, all the GLP-1 inhibitors right now, everybody wants Ozempic. They just can't keep up with manufacturing. So this is a massive demand increase. And for generics, the margins are so small, there's no buffering. So a brand manufacturer will have dual suppliers. They will carry more inventory. They will take a lot of steps to buffer this. There are a lot of things that I could list, but again, that just isn't an incentive. And the incentive trickles down. If we were to put more requirements on these manufacturers, a lot of them would leave the market. So it really needs to come from thinking through the buyers and sort of having these pull strategies. There are ways also to have the government support, but again, the market is not functioning in a way that we want it to. If we want resilience, we will have to pay for it, one way or the other. That's the unfortunate truth on that.
Thank you. Thank you, Mr.
Thank
Chairman.
my colleague, Dr. Cassidy.
Yeah, now, Dr. Hernandez, thank you for including the references, and I want my colleagues to listen to what I'm about to ask. In your reference number 7, you speak about how PBMs are paying pharmacies much higher than their acquisition cost, 1,000 times more, but then they potentially claw it back. What I've learned is that the health savings account covers, from Obamacare, covers both the pharmaceutical benefit and the medical benefit. And so the way this is structured, they're really using, theoretically, the PBM, that HSA as a piggy bank to drain from the patient in order to claw back and put more money in their pocket. That is a reasonable scenario of what's happening, correct?
So the problem is that the clawback data are confidential. So
I understand that.
Yeah. No, so it doesn't have to be about the health savings account. It can also be about payments paid out of pocket in cash. So I think the part
But either way, one fix of this is if we make the health savings account only for the medical benefit, it would eliminate the incentive to charge a high markup fee relative to the acquisition costs. Whether that's occurring or not, it would eliminate that incentive, and that's something that this committee can do. And we can talk about that more. But
I think Dr. Hernandez wants to respond again.
I disagree with you, Senator. I do think we need to prevent these markups. I think they should be prevented through increased oversight of the PBMs, because the problem with excluding the pharmacy benefit from the health savings account is that then patients may not be able to use it for things like expensive drugs for cancer. And, I think that's concerning because if you think the more expensive drugs are brand name drugs, right? And then there's also generic drugs. So I think
out of pocket, the alternative would be to have it covered under the medical benefit.
But the drugs that patients pick in the pharmacy are covered under Part D. There's also like oral expensive drugs.
I get that. So let's just talk about that because it does seem as if the HSA, and this is not Part D, this would be in commercial insurance. The Part D component of this, I'm sorry, the HSA component of this, which I think our committee governs HSA, not HELP, needs to be examined because I actually think that there is a negative incentive in order to use that as a piggy bank. But we can talk about that offline. Dr. Wazinski, one thing in Lafayette, Louisiana, or Youngsville, Louisiana, actually, based on a grant from BARDA, they are making low-cost N95 and sterile gloves. But the cost of that is still not competitive relative to China. Now, I like your thing here, and again, for my colleagues, I think I'm going to highlight on page 7, your third paragraph, that we strengthen sections, and I won't go through it, of the Social Security Act in order to actually increase the amount that CMS reimburses for this acquisition. Can you speak about that? Because in your testimony, you didn't delve into that much.
That's right. Thank you for the question. So CMS does have a tool where they are able to step in some cases. It's not it's not at all a tool suited for rewarding reliability because CMS would have to know who is reliable. But it's a really good tool, for example, that was used with N95 masks, where CMS wanted to reimburse hospitals for purchasing domestic ones. So this could be very much a national security type a scenario where the government decides we need to subsidize certain products. But the problem is the way the statute is structured is that CMS can only reimburse the IPPS or OPPS share. So let's say that I'm a hospital, I have a choice of buying $1 masks and $2 masks.
Or a little bit more expensive generic domestically produced versus one produced overseas with unknown reliability.
That's right. But if there is a price difference, I'm only going to get reimbursed for half of it, or if I am doing my IPPS is half. And that makes no sense as an economic agent. I'm not going to do it. I will have to spend twice the amount of money that I'm going to get reimbursed for. This committee could close that gap and think of certain situations.
Now, so let me stop you because I think you've made the point. But you don't want to continue to prop up inflated price. In Youngsville, they're continually putting in efficiencies to lower their net cost. And so how would you structure this so as to continue to incentivize lower costs for domestic production?
Yes, that's actually really important. This is, I think, where it should tie in with an HHS supply chain coordinator role. If we are CMS doesn't know which products would need to be, for national security reasons, need to be propped up, right? They need to be told by that. There needs to be an assessment of what is vulnerable to geopolitical risks and whatnot. And so in a coordinator role like this, they can also be assuring that if there's only one domestic manufacturer, that they're not going to start charging $1,000 per piece if the government is going to fully reimburse it. So they could have contractual agreements on the front end that if you're going to participate in this program, we're going to make sure you're not going to jack up the price.
Sounds great. And could I have the indulgence to have one more question, Dr. Weston? Yeah. Dr. Weston, you talk about how do we reimburse more for certain drugs in order to, the same sort of thing. You have to have a pull-through. You may have domestic manufacturing, but if you don't have a pull-through. When I was in the House back in 2012, I introduced the Patient Access to Drugs in Shortage. And I changed in my bill, never adopted, the Medicare reimbursement rate for generic injectable products with 3 or fewer active manufacturers from ASP plus 6 to wholesale acquisition cost. And it also exempted generic injectable products with 3 or few active manufacturers from Medicaid rebates and 340B discounts. One of you mentioned 340B discounts may give the purchaser the drug for pennies, which it's hard to believe that that is acquisition cost for an injectable. Any thoughts about my proposed legislation, knowing I've got a pride of authorship, but nonetheless, it seems still like a good way to go?
Senator Cassidy, thank you for the question. I'd be happy to provide more answers to that in detail offline because I know we're past time, but I think in general, the idea of being able to look at these drugs in shortage and being able to perhaps call out these drugs specifically to have a different reimbursement mechanism such that they're not pennies on the dollar, as you said, and basically having a race to the bottom cost-wise. So I think that your bill, I'm not familiar with the specifics of it, but I'd happy to look at it and get back to you.
And the question for the record will be for you all is to what degree, if we exempted these drugs from 340B and Medicaid rebates, how that would potentially benefit the overall industry. Is that enough of a market share, and I think it is, that it could actually increase the profit margin to continue production? With that, I yield.
I thank my colleague, and I want to get more of an understanding, because my colleague knows I very much like working with him. On this HSA point, it looked to me like what Dr. Hernandez was saying is the patient is going to eat the cost one way or another. They're going to eat it out of pocket, or they're going to eat it through the HSA. So let's just work together.
Yeah, and that's assuming that it's subject to the deductible. If it's not subject to the deductible, then it would not be an issue.
We will follow up with you, and we're going to talk to Dr. Bob Menendez.
Thank you, Mr. Chairman. Dr. Hernandez, in the market for generic drugs, sellers compete primarily on price, creating what I believe is a race to the bottom. Research has shown that the lowest priced generic medications carry substantially greater shortage risks. And in the face of narrow margins and declining profitability, some manufacturers exit the market for certain drugs or shut down entirely. Do you agree that the race to the bottom pricing is a driver of prescription drug shortages?
I do. I think your summary was very complete. As I said, I think drug shortages have economic drivers behind them, where the race to the bottom is one of them. The race to the bottom has been key also at, keeping costs down in Medicare and Medicaid and enabling, affordability of generic drugs. But in some cases, it has threatened market sustainability, as particularly it is the case of generic injectables. So I very much agree with your statement.
Now, wholesale distributors purchase drugs from manufacturers, they store them, they sell drugs to pharmacies and clinicians. These ventures collectively account for an estimated 90% of all domestic generic drug purchases and leverage their market power to serve as price setters for generic products. Do you agree that increased concentration among drug purchasers, such as wholesale distributors, is a factor in driving race to the bottom pricing and making our supply chains more brittle?
So we have concentration in two entities in the purchasing side, wholesalers and group purchasing organizations. Both of them are highly consolidated, with only 3 or 4 accounting for the majority of the market. Now, on the wholesaler side, we have wholesalers buying generic drugs from manufacturers for basically like 1/3 of the country because of the consolidation. That means that only manufacturers that can produce large enough volume are competitive to be in what we call preferred list of wholesalers. So that also leads to concentration in the manufacturing side. Now, in the group purchasing organization side, these entities, which are also very consolidated, aggregate purchasing power across pharmacies, hospitals, health systems, etc. They contribute to the race to the bottom because they are negotiating these contracts on behalf of a large number of members. Mm-hmm. But I just wanted to differentiate that there's the two types of entities.
Okay, I appreciate that. Dr. Wazinska, as we've heard, the generic drug market is one that largely encourages competition on price alone. This makes it challenging for generic manufacturers to invest in additional capacity, manufacturing upgrades, and quality control. As a result, manufacturers can experience quality issues that result in facilities going offline or drugs being discarded. Further, generic drug purchasers appear to have limited information about manufacturer and facility quality management. Are there sufficient financial incentives for generic drug purchasers to prioritize quality and reliability in their purchasing decisions? And if not, what financial incentives should we be considering?
No, they're definitely, the market does not reward reliability. I think it can be done on both sides. Definitely, it needs to be addressed through the buyers and change the weight that buyers place on reliability. That's by far is the most important thing. There have been a number of proposals, and in some of my work, I've also proposed that we do also direct investments and provide forgivable loans to help build up the infrastructure and help manufacturers directly get up to par. But that won't change anything if there's still the race to the bottom. So until we actually address how the buyers buy and what they wait, we're not going to make much progress. But if we start rewarding reliability and manufacturers can maintain actually a higher price point because it's rewarded, that reliability, then there's going to be an incentive that will follow.
All right. Finally, for anyone on the panel, for many drugs, Medicare is the largest payer in the United States. Medicare Parts A and B typically reimburse providers for inexpensive generic drugs as part of a bundle of services and supplies rather than on an individual drug basis. By design, these bundled payments increase downward pressure on pricing, and these cost constraints impact contractual pricing arrangements across the supply chain. Are there payment and contracting reforms that can enhance predictability and stability with respect to generic drug pricing, payments, and volume commitments?
So if I could actually speak, earlier there was discussion around unbundling payments and to what extent they would help. I just would like to emphasize that unbundling will help, again, if the price becomes a signal of quality. And just unbundling is not going to solve this problem. And the other witnesses spoke to that. And so the question is, can we get reliable measures around what is reliable? I have more detail about it in my testimony, but I believe that if we wanted to wait, especially for generic sterile injectables, if we wanted to wait for FDA to develop this, it will take time, but I think there are other ways for us to do it through a pay-for-performance program to engage hospitals in trying to do a better job of doing this homework, actually through the GPOs, because the GPOs are actually in a very good position. They already look at supply chains and the reliability of supply chains. They're just not being rewarded for selecting the more reliable manufacturers on their contracts.
Thank you. Thank you, Mr. Chairman.
My colleague, Senator Johnson.
Thank you, Mr. Chairman. I think we need to focus a lot more on the root cause of this problem, and we're getting close to it. I think a number of the witnesses have said it's the low prices, it's the race to the bottom. I think you have to find out, well, what's causing that? Now, I haven't heard the word monopsony purchasing power yet, where you've got basically the federal government with their drug formulary pretty well driving most of these prices. I would ask the witnesses, can you think of a common consumer product that is always in persistent shortages? Can anybody think of one? There may be some, but the reason there aren't is you've got millions, billions of consumers, and the marketplace takes care of all these problems. It demands higher quality. It demands better levels of customer service. It demands the best price. But because we have the federal government getting involved in the healthcare marketplace, it screwed everything up. Third-party payer systems through insurance is another kind of monopsony type of purchasing power as well. So we need to focus on what can we do to bring consumers back into the process here. I'm a manufacturer. I supplied medical device industry for years. We actually were able to, and our customer allowed us to charge a higher price to stabilize their price over a number of years, but also to ensure supply. Mr. Coquille, that's basically your company's approach to this. You increase costs by having buffer stock, correct? So you're able to provide a service. You'd probably be considered a middleman. And because if your company makes any money off this, generally the members of this committee would be criticizing you for skimming off the top and driving up prices, but you actually provide a service. Isn't that correct?
Thank you, Senator. We're a manufacturer, but part of what we do in contracting with hospitals is bypass the middleman in the transaction. So we work directly with hospitals. We don't go through the GPO contracting process.
That's a marketplace solution, okay?
That's a marketplace solution.
Dr. Wazinska, because when we were talking about PBM reform here, which, by the way, I'm the only one of this committee that voted against what the committee is trying to do here, because I don't understand how it's going to fix any problem. One of the questions I asked staff was, if this is going to lower prices for consumers, why is Big Pharma in favor of the PBM reform that they're proposing? Again, we're talking about right now shortages caused by a race to the bottom, too low prices. I mean, isn't it true that PBMs are negotiating lower prices for the organizations they're representing, and it's just not transparent in terms of how those prices get benefit consumers, because it benefits them in lower insurance costs and that type of thing. You want to respond?
Yeah, so PBMs really play a role in the oral dose market, not generic sterile injectables. They don't deal with hospitals. And really their role here is because they are a major pharmacy. This is the vertical integration. That's the piece, really not the contracting, but the fact that they own mail order pharmacies and that they also have specialty pharmacies. And just like any other specialty, they're incentivized to bring the lowest cost. What they mark up and how this is this shows up to the payers is a difference.
They're putting downward pressure on drug prices, correct?
Yes, there's absolutely downward pressure. And just to your previous question and your previous point about sort of where things break down and why is it that the consumer suffers, I just would like to highlight this. There's a lot of players in the chain, and each one of them is incentivized very differently, and they don't internalize the harm that results to patients. And I will say it's including, if you think about the cost on hospitals from shortages, $360 million, that's $60,000 per hospital.
In a free market, there would not be these shortages, certainly not with generic drugs. It just wouldn't occur, but it's not a free market. Government has interfered and screwed it all up. One point I want to make, is I think this is an enormous national security threat, is the fact that we do not, by and large, produce precursor chemicals. We do not produce the active pharmaceutical ingredients. I'm not for general economic engineering, but in this case, I think we do need Buy American provisions. Now, again, as you said, we're going to have to pay higher prices, but one of the reasons you have these huge markups, from the middlemen, is when you have a shortage. So if you didn't have those shortages, you wouldn't have those instances where people are responding to the marketplace, driving costs up 1,000 times. If you eliminated the root cause of the shortages, bring back more consumerism, get rid of the monopsony type of buying power, that'd be a solution. But we do need to address, and we haven't. We have this infrastructure bill. I don't think we spent a penny on trying to bring back the manufacture of precursor chemicals and API to America. That is an enormous national security threat, and we're just ignoring it. Anybody want to comment on that?
If I could speak to this briefly, I completely agree with you that we need to be thinking about sort of the geopolitical threats. Where we face a challenge is that the enormity of this problem. To onshore everything into the United States, I don't know, trillions of dollars. What we need is to be really strategic about what are the essential medicines and which ones are really vulnerable.
It would not be trillion. It wouldn't be trillions. Again, the marketplace would respond to it if we allowed the marketplace to do it. But we're not. We're trying to do this through government control, and again, just government screws things up.
The time of the gentleman's expired. Senator Carper is next.
Thanks, Mr. Chairman. Welcome, one and all. Nice to see you. A question regarding Medical Supply Chain Resiliency Act. COVID-19 pandemic taught us a bunch of different lessons, as you know, about the resilience of our nation's supply chains, especially with respect to with medical supply chains. Across our American, certainly in my home state of Delaware, but we've heard from patients, we've heard from caregivers, we've heard from providers, we've heard from manufacturers about the lack of access to medicine and to medical equipment and how that impacted their lives. The aftermath of this once-in-a-generation health crisis emphasized that we, as lawmakers here and across Capitol Hill, need to take action to shore up our access to goods around the world. No one should have to worry about not being able to access the treatment that they need. That's why I work with one of our colleagues on this committee from North Carolina, Senator Tom Tillis, to introduce the Medical Supply Chain Resiliency Act. Our bill, as you may know, would give the President the authority to collaborate with our allies across the world to help diversify our supply chains, to increase access to critical medical goods, and to mitigate the effects of public health crises. Today, the medical supply chain backlog continues to affect access to life-saving medications, with over 140 medications listed as active drug shortages, over 140 by the FDA. Improving supply chain resiliency in the U.S. has never been more important. A question, if I could, for Dr. Hernandez. Dr. Hernandez, in your testimony, you emphasized the importance of drug manufacturers to build resilient supply chains. Can you just discuss with us for a couple of minutes how we as lawmakers can incentivize drug and medical product manufacturers that invest in secure supply chains?
Thank you for the question, Senator. I think the idea could be to pay more providers when they select drugs from resilient supply chains, and there's some discussion about how that could be achieved in terms of how you could set up the payment system, but the idea would be that to not reimburse always the same regardless of the generic version selected, but rather reimburse more when hospitals and potentially pharmacies purchase drugs from manufacturers that have invested in redundancy, in upgrading factories, in upgrading equipment, in having some backup production lines, for instance, if the first one shuts down. So I think that could be the idea.
Thank you. Thanks very much. A second question, if I could, for Dr. Wasinska. How do you pronounce your name? Wasinska? Okay, thank you. A question on lessons learned capacity building. We've heard discussions that in efforts to produce generic medications inexpensively as possible, drug makers are limited in their ability to invest in building manufacturing capacity and ensuring quality. We've seen several instances where demand for a drug is underestimated, and then we're caught unprepared and unable to adequately ramp up production. For example, last fall, and I think last winter, we saw a crisis of children battling an early severe flu season alongside RSV and COVID-19 surges. Hospitals were at capacity while parents were facing empty shelves where children's over-the-counter fever and pain reducers should have been. Even members of my staff have shared stories of the fear they experienced while caring for their own children when they became sick with fevers without access to medication, as simple as Tylenol. The unexpected high demand for these common medications led to their shortage, and yet they were not included on the FDA's drug shortage list. It's clear that we need to work together to find a long-term solution to build manufacturing capacity and oversight to ensure we have the capacity to, capabilities rather, to adjust and meet demands as they arise. Here's my question. I often say that we need to find out what works, do more of that. In that spirit, what do we learn from the shortcomings like this, and what actions should the Congress, and in particular this committee, consider in order to ensure that we're prepared for a future crisis that faces such unexpected demand?
Thank you for this question. It's a really big question, so I'll just highlight a couple of things. So preparing for dramatic demand increase, it can be done two ways. One is by having inventories of materials or finished dosage product. Another way is to have spare capacity and be able to turn it on quickly. So those are sort of the two ways in which you can ramp up production, or have technology that's flexible enough that where you can sort of switch the line to something else. So those are sort of the ways through which one can prepare for increases in demand. And that's actually sort of the space where BARDA has been really active, because it is, in a sense, that's what pandemic preparedness is, or CBRN threats. Those are all about massive demand increases for products that can occur, which is somewhat different in terms of how we prepare for this than for manufacturing quality problems and the sort of economic drivers that we described.
All right. Thank you both. Thank you both.
time my colleagues expired. We're going to try to just keep going and get all the way through this. Senator Blackburn, you're next.
Thank you, Mr. Chairman, and thank you all for being here so that we can discuss this issue. Vanderbilt is in Tennessee, where I represent it. They have been dealing with 175 drug shortages for things that they're needing. And of course, we know all across the state, we have different providers that are dealing with this. Now, at Vanderbilt alone, more than 100 staff members are engaged in trying to manage and mitigate the disruptions that are caused by these shortages. And recently, there was an incident that occurred with a vital chemotherapy that highlighted the severity of the issue, and the medical center faced the possibility of having to form an allocation committee. And they thought this is going to be a daunting task. Fortunately, a shipment arrived, and so they were able to avert the rationing. But this is something that is becoming all too common with our providers. So we appreciate that you all are here with us today. Mr. Cockle, I want to come to you, and I think I'm saying your name right, am I? Okay. Talk a little bit about how long-term purchasing contracts with hospitals and health systems play a role in prioritizing the production of generic drugs, and how they have an impact, or what type impact they can have on the drug supply chain.
Yeah, thank you, Senator. If we treat generic drugs like commodities, then the market will function like commodities. So if I want to buy a load of soybeans, I can buy a load of soybeans today and buy from somebody else tomorrow, but it doesn't create any long-term relationship or commitment between buyer and seller. But when the hospital or the purchaser enters a long-term agreement with a manufacturer, then that manufacturer is going to reserve line space. We'll know they have a market for that product for a period of 2 years or 5 years or whatever it is, and they will continue to be there to meet the needs of their customer.
And then with the model of Civica RX, talk with me about how that helps to stabilize a supply chain and the impact that that has.
Yeah, thank you, Senator. So by having those long-term purchase commitments in place, we're both able to ensure that our manufacturers are there for the long haul, and that we vet them for quality so they're less likely to have a supply failure. But we also then have predictable demand from the hospital because they've committed to a certain volume. And because we have predictable demand, we can then build up a buffer inventory of around 6 months worth of drug. So we're always selling the older stock and continually replenishing it. And if something happens in the market, either with our own supplier or somebody else, we have a 6-month buffer inventory to continue to supply through that interruption.
And to work through it. Dr. Wazinska, I want to come to you. Do you think, as we're looking at this issue of the unpredictability in the supply chain, should it be mandatory that hospitals develop a plan, a contingency plan, for potential shortages and a management plan for their supply chain of pharmaceuticals?
That's an interesting question. I haven't thought about a mandate like that. I have really been taking an approach of trying to change the hospital incentives really more through carrots. To have a hospital carry buffer inventory of all the products would be quite a tall order, and not all of them are just as, nearly as vulnerable. So here again, I think hospitals might be better positioned than their GPOs in figuring out what is more vulnerable than CMS coming in and say, this is essential and this is vulnerable.
So how do you talk about those incentives? What would those incentives be? How would you encourage hospitals to commit to long-term purchasing contracts?
So the proposal that we have put forward is not as specific to tell hospitals what to do. The proposal that we have is a pay-for-performance program that really looks at really two metrics. let's say that there was a shortage of a drug. You look back to when the shortage, before the shortage, as the shortage was starting, who were you buying from? Were you buying from the more reliable one? Oh, you picked wrong. Did you have buffer inventories of this product? So I don't really, it doesn't really matter whether they had long-term contracts or not. It would encourage long-term contracts. That's how the hospital assures that for their high-risk products, they actually have committed product and they actually can get it from the more reliable manufacturer. But with this sort of comes in, it's more of an outcomes-based pay for performance rather than, take these behaviors, they have to be 2 years, 3 years. How do we know what's the right length, right?
Yeah.
And I'm not sure that CMS is in a good position to sort of really kind of judge like all the little pieces of it.
Time of my colleagues expired. Senator Tillis is next.
Thank you, Mr. Chairman. Thank you all for being here. Mr. Weston, just not too long ago, I voted for the CHIPS Act. And one of the reasons I voted for that is that we need to have a supply chain resiliency in the semiconductor space. I think there's an analog here in terms of how we bring back manufacturing to the United States. But by itself, particularly for the lower margin drugs, we have so many obstacles that we have to overcome. I'm kind of curious if you could expand. I would see regulatory burdens being one of them. I can see just cost basis here, a lack of tax incentives, those sorts of things. But and anyone else that wants to speak up, what should we be thinking about to make either the United States a better jurisdiction to address some of our supply chain vulnerabilities or friendlier jurisdictions? I've got a particular interest in jurisdictions in this hemisphere. I think Mexico or Latin and South America, but can you give me an idea of your thought, or give me some of your thoughts?
Thank you, Senator. I'm a cancer doctor and not an economist, so I will defer to some of my panelists here to give some thoughts on that. However, what I would say is that this is an ongoing issue that really does need to be addressed in the way that you're talking about, to have additional resiliency. So we look at semiconductors or other national security issues. Not having access to generic drugs in some ways is a national security issue.
Well, and Dr. Walensky?
Yeah, I would be happy to speak to this. The CHIPS Act is a great example of how something like this could be done. The big difference from semiconductors is that we're talking about 20,000 approved drug products. Each one of them has many phases and many facilities, 16,000 facilities, right. Key starting materials. So the framework is good, but I think what we need to layer on top of that is really an analytic approach on how we choose what is most important. And in my testimony, we have with colleagues put forward a framework for how the government should prioritize which supply chains are important. And I'll give you an example. Cancer drugs are not on the essential medicines list. Right, so one of the pieces that needs to be thought through again is what is essential. Another piece is what is really vulnerable. Going back to trade and so on, we need to be thinking about not just everything in the U.S. that's not possible, but thinking about potentially friendshoring, nearshoring, and also thinking about full supply chains. If the federal government were to move an API facility, active pharmaceutical ingredient facility to the United States, but all of the upstream still comes from China and all of the key ingredients still come from China, then what problem did we solve? That's not a good use of taxpayers' money. So we need to be really strategic in that approach in how we do it, and then we can take the steps that you have taken in the CHIPS Act.
Mr. Cockle?
Thank you, Senator. I share your concern and desire to see a strong domestic industrial base for pharmaceuticals. I do think it's helpful to think about what's the problem we're trying to solve. So if we're trying to solve for long-term geopolitical risk, we absolutely have to think about that whole supply chain from end to end. If we're trying to solve for the shortages problem that we're experiencing right now, most of the problem is with the finished product. And so there we have to ensure we have a robust infrastructure to produce that finished product. And once you've got a facility there, that can typically make many dozens of different drugs. Mm-hmm. But right now, at today's prices, few manufacturers can invest the capital required to build a brand new manufacturing facility.
Yeah. Any suggestions on how to fix that?
Well, in my testimony, I start with a very targeted proposal, which is just to say there are certain drugs that we can say with high confidence are going to go into shortage, mainly because they've been in shortage recently. Some of those sell at prices that are so low that no manufacturer in the U.S. could make them competitively and is going to invest in bringing them to market. but at a cost of about $3 to $4 million per drug, we could make sure that there's a U.S. manufacturer that has that product, that's done all the analytics, sourced the API, got the commodities sitting there, has the FDA approval, and when that drug goes into shortage, you can turn that line on and produce that drug in the U.S. That's a pretty cost-effective insurance policy.
Thank you all. Thank you, Mr. Chair, I just wanted to mention something else. Thank you all. We'll also have some questions for the record for all of you. But, Mr. Chair, I just wanted to mention, and I was very happy to be a part of the bipartisan PBM reform bill that came out of this committee recently. I'm hearing some rumblings that it may get paired with some not-so-popular provisions as it moves through the Senate chamber. I don't know if that's correct, but I just wanted to lodge my concern because I really do hope that we can continue to work on getting that through and getting it over to the House.
We're going to be focused on getting this passed, and what has put us in this position is working in a bipartisan way, and Senator Crapo and I were just talking about that this morning.
Very good.
So
thank you.
Look forward
Thank
to
you all
talking.
for being here.
Senator Brown's next.
Thank you, Mr. Chairman. Ms. Wyszynski, thank you for your comments. I want to take off on that, but my question is really to Mr. Cockle. I introduced with Senators Blackburn and Peters the Rapid Reserve Act. It would require DHS to award contracts to generic drug manufacturers in order to keep reserves, if you would talk to Ms. Wyszynski, of active pharmaceutical ingredients and finished products that we can easily turn to during drug shortages. We shouldn't, you know this, we shouldn't have to rely on foreign countries, in many cases foreign competitors, for the drugs Americans rely on. A stronger domestic pharmaceutical supply chain will help to prevent those shortages and those delays. Goes without saying. Mr. Cockle, you discussed in your testimony a proposal to invest in the domestic manufacturing of essential drugs at risk for a shortage, a similar concept, different but similar to the bill that we have put forward. Elaborate, if you would, on the benefits of implementing these types of government contracts.
Thank you, Senator, and thank you for your work with the others that you mentioned on Rapid Reserve. We supported it when it was introduced and continued to support it. The concept there is to have a contract to produce API, to take that through to finished drug. And as you say, that's quite similar to what I talked about. The one difference is what I talked about today really doesn't, it creates an insurance policy so the manufacturer is ready to produce when the shortage starts. But doesn't assume that the production is ongoing. But otherwise, they're very similar concepts in terms of creating the readiness to manufacture in an economic environment where otherwise we would not have that.
Thank you. And Dr. Hernandez, question for you, if I could. The U.S.-China Economic and Security Review Commission a couple of years ago recommended that Congress direct the FDA and other federal agencies to identify alternative sources for APIs and other ingredients, including utilizing the Defense Production Act. Last week, the administration announced plans to implement some of these recommendations. Congress has already provided some resources in the administration to use DPA authorities to ramp up production of medical supplies, including generic pharmaceuticals. I fought to include this in the CARES Act that Congress passed a couple of years ago. One domestic company, National Resilience, has already secured a DPA loan to expand domestic manufacturing capacity of essential medicines in a community called Westchester Township, north of Cincinnati. Your testimony, Dr. Hernandez, highlights how drug shortages are a matter of national security. Can you speak to the importance of additional resources for authorities like the Defense Production Act? And also, as you answer that question, what are some additional authorities that the U.S. government can use, including DPA, to bolster the domestic manufacturing of pharmaceuticals?
Thank you for your question. I'm not an expert in national security. It's just evident to me that this is a vulnerability, but I'm not an expert. I'll be happy to review this and get back to you with a written answer for the record.
Okay, thank you. DPA is something not especially well known around here in the country, but is something that a lot of these issues, whether it's fentanyl smuggling into the country, whether it's crypto's use internationally for various onerous uses, can come under, or certainly our national security issues. DPA may be in place to answer some of those. It may not. That's what we're trying to explore, and we will follow up with you. Thank you. Mr. Chairman, thank you. Yield back a minute.
I thank my friend. I'm not going to be filibustering here. We are waiting for a couple of colleagues, and we have a vote coming up. I mean, it seems to me as we get close to the end here, we are talking about significant market failures. It seems to me we're talking about a whole array of incentives that are out of whack and some interest in how to use Medicare in a smarter and more creative way. Is that a fair summation? Would any of you like to speak for about 20 minutes or so? No. We've got a couple of colleagues on the way, and we'll see if we can continue this discussion. And I thank my friend from Civica for volunteering to spare me the filibuster.
I can't promise you 20 minutes on any topic, Senator, but I will take the opportunity to bring up something that CMS actually recently proposed in their annual hospital payment rule, something that they didn't ultimately decide to go forward with, and I think could use a little fixing. But the concept is sound, and what the agency said is we propose to pay hospitals a little more if they keep a buffer inventory for essential drugs or arrange for somebody to keep it on their behalf. And I think having it held upstream from the hospital makes a lot of sense for a number of reasons. But they were using an existing, or proposing to use an existing Medicare payment authority to just say, we recognize that it may cost a little more to have that extra buffer inventory of essential drug, but that would be a good thing to do, and we'll pay a little more for it. So it's exactly along the lines that you're talking about, and I think it's an idea that this committee could come back to.
And what happened to said idea? Did it get formally proposed? Is it on the table now?
It was formally proposed in the hospital prospective payment rule, but they decided not to move forward with it. And I think they got mixed feedback. And as I say, I do think it's a rule that, as it was proposed, could use a little adjustment. But they did propose it.
We will look at it. Senator Bennett is always worth waiting for. And
That's not
he's
true.
recognized for his
That's
question.
never true, Mr. Chairman, but thank you very much for holding on to things. Ms. Wozinka, thank you for your testimony. Thank you, everybody, for your testimony today, for being here in this hearing. Let me start here. I'm hearing from many constituents that sometimes the brand ADHD medication, Adderall, is often available, but the generic version is not. And this is obviously more expensive for families. Many families can't afford the higher out-of-pocket costs. I don't think parents should have to make these choices. They don't. And to be honest with you, I'm hearing story after story after story of families that are dealing with this not just this problem of generics versus not, but also just the availability of the medicine at all. Could you explain what's going on here and what we need to do to fix it?
Thank you for the question, and thank you for the opportunity. I'll have to start by saying that when a good friend of mine heard that I am going to testify, the first thing she said to me, she's like, can you talk about ADHD? Because I can't find the ADHD medication for my son.
Please
the ADHD,
give your friend my regards.
Yes, I will.
Yeah.
This is actually a very different shortage. The shortage is driven to a large extent by an increase in demand for the product. And we are in a system where there are challenges in sort of expanding. There's another agency involved, the Drug Enforcement Agency, that has a cap on the amount of product that can be produced, and then they also assign basically market share to manufacturers, the manufacturer quota. And if, it's not we're the only jurisdiction that really has this kind of a system of dealing with potential misuse of controlled substances. And so what ends up happening is that, you put a cap, there's more people that want it that they want, and somehow we're supposed to sort each other out, that the patients that really need it get it, and the ones that are taking it to study for exams and stay up all night don't get it, that there's no system for that. The cap doesn't do that. And then there's also challenges with how the manufacturer quota are assigned, because they tend to be assigned based on historical purchases. That's why in those markets and for controlled substances, the brand frequently gets the largest market share. And it's by how the manufacturer quota are assigned. So,
why do they get the biggest market share?
because they have to give quota to manufacturers. The DEA has to, manufacturers apply for
so
quota.
the DEA, so there's first, or maybe these aren't in order, but there's a cap.
There's a cap.
And then as a consequence of, or in addition to that, they have to assign a quota to the
That's
brand
right.
name
And they have to
parts of it.
decide who gets it, and it tends to be, here's another interest, one drug, Vyvanse, went generic this summer. There's 14 generic manufacturers that want to go up for it, and it's a big mystery to everybody how DEA is going to assign the market share to those 14 because they have no historical purchases of this, right? There were no generics prior to that. So this is not within the jurisdiction of this committee, but I do think this is a very worthwhile conversation to be had.
And do you think that, this probably isn't within your jurisdiction as well, but are the demand issues you're talking about, are you familiar with what's causing the increased demand for the drug?
So it's not well documented. We know in which age groups this is happening.
Yeah.
This is not happening in Medicare. This is happening with young adults
Yeah.
and sort of, 30-year-olds.
I mean, I think that you could probably draw a pretty straight line, or maybe a line around the COVID epidemic and the shortages that we're seeing. That's when we started seeing this at the Target, around the corner from our house. And families started to tell me that they were going to 20 pharmacies, 25 pharmacies to try to find the medication for their children that had been prescribed. And I suppose this is an issue to raise with the DEA as well in terms of their
On
cap.
the supply side, definitely, and on the demand side, the FDA does have what's called REMS authority, where if certain patients should be getting this and it should be used in certain situations, there are ways to put in programs to try to sort of control the demand side of it. So there are other mechanisms to engage.
Well, thank you for your testimony. Thank
Absolutely.
you. Tell your friend I said hello.
I will
and
do
Mr.
that.
Chairman, thank you for holding it open.
Senator Bennett, as usual, you're raising a very important issue. We've been banging some heads at DEA and FDA, and particularly trying to force some disclosure with respect to whether these manufacturing quotas are being met. So we'll have some more to talk about, and absolutely. Let's see. Senator Whitehouse is next, and then our colleague, Catherine Cortez.
Thanks, Chairman.
Yeah.
Thank you to the witnesses for being here with us. I think many of us know that conditions like ADHD and, to some degree, autism are often treated with prescribed stimulants, and that patients experience considerable benefit from those. And they also experience considerable difficulty getting access to the drugs. My office has been contacted by a mom in Riverside, Rhode Island, who has an 11-year-old, and it has had to become really a almost daily project of the mother to try to call around to pharmacies, see where there might be some supply, to try to get to there while there still is supply. There's a 20-year-old in Lincoln, Rhode Island, who's had a similar experience. To be more specific, a prescription from August of this year, they've not yet been able to fill. So let me start with Dr. Weston. When you face patients who are having these problems, what does it do to your world and your workflow?
In the cancer world, it's certainly different than having to call around for pharmacies for your child to not get prescriptions. That's a very big problem. But in our line of work, we're dealing with literally life-threatening conditions. And so not having access to medications for us, having to call different pharmacies would be a welcome alternative to dealing with potentially not being able to deliver life-saving therapies.
But the point is that this work backs up into physicians'
Absolutely.
offices.
This has an
whether
impact
it's
on physicians
cancer or
as well.
otherwise,
Correct.
And adds to the load and the burnout and the wear and tear
Absolutely.
on physicians. The drugs I'm talking about are controlled substances. They are regulated by DEA. One of the regulatory procedures that is used is an overall limit on supply, which seems like an unusually blunt instrument. I'm getting a lot of head nodding on that. Tell me a little bit, maybe Dr. Wasinska, about the time lag between when somebody in DEA makes a determination that a particular supply limit should be imposed and how long that persists in time until it is implemented and ultimately amended. How long can the gap between the decision and the actuality of the limit be?
Thank you for this question. All I can really speak to is the fact that these lags exist. From what I understand, they can take months, and frequently a manufacturer might not obtain all of the quota that they asked for. So it's sort of this repeated process. And there's, from what I understand, really challenging figuring out what it would take to have DEA give you the quota that you want. But this is probably a much better question directed at manufacturers, and I'm sure that AAM would be able to speak to their experience that, and I would recommend.
If there were a demand surge during that time period, the people who have the prescriptions that make up the demand surge are just stuck, right?
That's right. I mean, that's right. So one is the overall demand, and then also the process of assigning quota to individual manufacturers and trying to sort that out. And frequently, they're not. The manufacturers are not given all of it at once. So it's.
Would it make sense? You know, we've got a strategic petroleum reserve where we hold certain reserves back in the event of an emergency need. Would it make sense for DEA to allow supply reserves that could be released in the face of a demand surge?
I will say I don't understand why the quota system, why we think the quota system in the first place are a way to deal with misuse and abuse. Again, you know, we put a cap.
Pretty blunt instrument at the end of the day.
It's a very blunt instrument that only is used in the United States. You know, it basically puts a cap, and then patients have to sort each other into like, well, I needed more than you. We don't have a mechanism to do it. So I don't even understand how that mechanism is supposed to help.
For the record, my office interactions with DEA trying to get clarification for constituents have been unsatisfactory. Last question, Dr. Cockle. We've talked about the role of regulatory limits with respect to controlled substances. Do you see a risk here where you have monopolies, single use or single manufacturers for particular drugs who can withhold supply to boost their pricing prospects and capabilities and put a supply-demand inefficiency into the system to their benefit?
Thank you, Senator. I would say when we're talking about drug shortages, in general, what we're talking about is actually the opposite challenge, which is there are a number of manufacturers, and the consolidation among purchasers drives that price down to unsustainable levels. The time then when the price can surge is when the drug goes into shortage, and there's only one manufacturer left that has product to sell, and then the cost of the product can go up 10 or 20-fold. And so it's that market instability, really, that we're trying to address when we talk about the problem of shortages.
Thank you.
I thank my colleague from Rhode Island, Senator Warner.
Thank you, Mr. Chairman. Thank you for holding this hearing. And I hate to say good things about my colleague from Rhode Island when he's actually physically here. But you know, the idea of a reserve, a supply, you know, frankly, BARDA was part of that, but in this host of other drugs, I think it makes an enormous amount of sense, and love to work with you. I know you've heard lots of stories. I was going to tell a story about a patient or a constituent in Virginia Beach who loves being in Virginia, but lack of access to chemotherapy drugs. But I want to take my time, actually, and hope, Mr. Cockle, that you've not gotten this kind of full attention from my other colleagues. But part of the solution, I think, to what we're talking about today, we actually have got a pretty cool idea happening in Virginia. with Civica RX. And Civica RX is housed in Petersburg, Virginia, a community that had Boehringer Ingelheim at one point, but not necessarily historically known as a center of pharmaceutical manufacturing. But over the last number of years, there has been a pharma manufacturing cluster created in Petersburg. This coalition was awarded $53 million in the Build Back Better Regional Challenge grants, and it was recently named as well one of the 31 tech hubs, at least in terms of the preliminary piece, by the Department of Commerce. So we think this is an exciting idea. One of the stakeholders is Civica RX, which is founded by a series of hospitals and philanthropists who said, we got to try a different model. The notional idea of a nonprofit-based model that says, particularly around generics, because we know that so many manufacturers, the pricing point has gotten down so low that they don't stay in the business. And I say this as somebody who's the father of a type 1 diabetic, and one of the drugs I know that you're looking at is insulin. So this group of investors came together to say, how can you get a predictable, reasonably priced supply of certain medicines? And there is a series of drugs. Civica RX is going to be, as I mentioned, dealing with insulin, but other critical medications as well. So, Mr. Cockle, it's clear that you have maybe found, if not the full magic bullet, at least a part of the solution. And if we could have that predictable, yet affordable supply of particularly generics, I think it's terribly important. In the most recent Medicare hospital funding rule, CMS proposed but didn't finalize an idea to provide financial incentives for hospitals to maintain that buffer of essential medicines. Do you think what Medicare and CMS are proposing makes sense? And what else can Medicare do to make sure that very exciting solutions like you guys are working on can become a reality, not just in Virginia, but across the country?
Thank you, Senator. We're really pleased about the growth of the pharmaceutical cluster in Richmond and Petersburg, and proud to be part of the Commonwealth. Along with insulin that you mentioned, we've got about 36 products in development for that facility, with more to come, and we'd love to have every hospital in the country as a member. In terms of how we think about using CMS authorities to drive the purchasing towards more resilience, that rule that you mentioned, I think, is the right kind of idea. And essentially what they said is, we recognize that it costs money to hold buffer stock, but we recognize the value of that, and so we'll pay a little more so that hospitals can contract with somebody to hold that buffer stock, or can do it themselves, which I think is probably not the way we want to do it. But to say, yeah, if you contract with somebody, pick your essential drugs and contract with somebody that's going to hold that 6-month buffer stock for you, we'll pay you a little more, and then that way we will create a market for the entity that's holding on to that extra stock.
Well, I think it's a very exciting opportunity. I hope that, and as we've talked in the past, if there's ways we can incent other hospital systems from even the job owning standpoint. But the whole idea of this coalition of hospitals, philanthropists, and others coming together to actually create a nonprofit approach is unusual, unique, and long overdue. So I hope, Mr. Chairman, it can be part of our longer-term solution.
I thank my colleague. I want to tell our witnesses what's going on, because they've seen senators sprinting hither and yon. Our last two questioners will be Senator Hassan and Senator Warren. Thank you very much for wrapping up. I just want to pose one matter to you, Dr. Wasinka, for the record. All year we've been trying to bust heads with DEA and FDA with respect to this drug shortage issue. And the DEA finally, after we just pushed and pushed and pushed, has laid out some changes to how they set quotas for how much of these medications and other controlled substances each manufacturer can produce. Obviously, there's a lot more to do. And the question I'm going to want to ask for the record, if you could get it, say, in a week or so, is whether these unique challenges around shortages for controlled substances are an area that we can tackle here in the Finance Committee? And I suspect there are, and we're going to just ask you to do that in writing, okay?
I will follow up on that.
Great. Senator Hassan, and then Senator Warren, and Senator Warren will close the hearing. And I thank all our guests, and sorry for the sprint, but this is the way it is on Tuesday. Thank you.
Thank you very much, Mr. Chair, and thank you to the witnesses for being here and for your indulgence as we balance votes and the like. I'm really grateful for the topic of today's discussion, and I want to start, Mr. Cockle, with a question to you. In your testimony, you point out that most drug shortages in the United States are really predictable, highly predictable. While manufacturers could fill gaps in the market by investing in medications that are at risk of shortages, companies have very little incentive to do so because the margins on generic medications can be so low. It's clear that the federal government could do more to prepare for predictable shortages. If we already know what medications are at risk for shortage, what role should the United States government play in preparing for inevitable shortages of essential drugs?
Thank you, Senator. Yeah, shortages are highly predictable, and we can look at a range of factors in terms of which manufacturers are making them and where are they getting their active ingredient and so, but the strongest predictor of a future shortage is a past shortage. And if we could just solve for the drugs that have been in shortage over the past 10 years, we would solve a huge amount of the shortage problem that we're dealing with. But as you say, some of those drugs are selling at prices that no U.S. manufacturer can justify the investment to bring that drug to market,
right,
knowing that they're competing against somebody that's selling it at 50 cents a vial.
Right.
So if the government were to say, we know based on history and based on today's market prices that at some point somebody's going to step away from that drug and make something else, and we want somebody ready to step in and deliver that drug to patients when we need it, then the government could invest and have manufacturers in the U.S. ready to go to bring that drug to market the second or soon after a shortage starts.
Okay, thank you. Ms. Wysinksa, right? Have I got it? Let me ask you a question. Hospitals in New Hampshire, including Dartmouth Health, are experiencing shortages of a range of medications, including antibiotics, steroids such as hydrocortisone, and life-saving oncology medications. We have really small hospitals in New Hampshire. A lot of our state is rural, and they are at the greatest disadvantage during shortages because they have less buying power and fewer staff available to navigate the shortages. Unfortunately, hospitals often have virtually no information on the supply chain used by a manufacturer or the manufacturer's track record when they're purchasing medications. This makes it really difficult for a hospital to reduce the risk of shortages by choosing to work with reliable manufacturers. So how can more transparency help hospitals avert and respond to medication shortages in the long run?
Thank you so much for this question. So I would say that it depends what is the situation, because the information depends on the situation we're in. A hospital will need very different information during a shortage, right? They will want to know what is the allocation mechanism that the wholesaler is using, when might I get more product. There are also questions, how long will it last? That's a really hard question to answer.
Right.
Having worked at the FDA closely with the drug shortage staff, they frequently don't know how long it will take because they don't know how long it will take the manufacturer to resolve it. The manufacturer might not know at the beginning. Right. So definitely during a shortage is different. Before a shortage, the questions are somewhat different. This is actually where I do think GPOs can be really helpful because GPOs can help a hospital maneuver what is more reliable. They can participate in programs where there are actually buffer inventories. Some of the GPOs have them. Civica definitely is open. So there are definitely ways. I would like to take this opportunity, since you mentioned that you're speaking about small hospitals. I actually pushed back against the buffer inventory idea that was mentioned a couple of times that CMS put forward. And one big reason was that the mechanism, it would not be enough of an incentive for hospitals to use the program because it wouldn't pay enough. And also, the small hospitals are the ones that usually get left behind in a shortage.
Yes.
I will tell you, I have seen data that large hospital systems have gone from 3 weeks of like cisplatin and carboplatin in their inventory to 6 months.
Okay.
They are in a much better position to do this. What we need to be doing is buffering those that usually get left behind.
Okay.
If you will see in my testimony, I actually propose that rule that CMS used, that they are also able to potentially target who, not just which product, but who can get that subsidy, and then we
Okay.
can buffer them more.
Thank you. And I'm just going to move quickly, Mr. Cockle. How does your organization's focus on U.S. manufacturers affect the reliability of your supply chains for products like vials and pharmaceutical agreements, as well as the cost of your medications? Because we're talking about transparency here. How does the focus on U.S. manufacturers help in that regard?
Yeah, thank you, Senator. We feel strongly that when the manufacturers in the U.S., we can have the insight we need into their quality system and their track record, and also that the FDA is there on a regular and consistent basis. Which not to say there aren't good and bad manufacturers everywhere, but we have that insight. And so we do prioritize U.S. sourcing, but we also think it's the right thing to do from a long-term national security point of view.
Okay, thank you very much. Thank you.
Senator Warren.
Thank you. Thank you, Acting Chair
Yeah,
Cardin.
I just all of a sudden moved up in seniority to chair the committee.
There we go. So I'm really glad we're having this hearing today because there are more than 300 drugs that are in shortage, meaning that companies don't produce enough to meet patient demand. That is more than any point in nearly a decade. And shortages can be devastating. They force patients to use less effective alternatives or to switch drugs that may have more harmful side effects. Lots of factors can cause shortages that you all have been talking about today, spikes in demand, a manufacturing facility hit by a hurricane, or an inspection problem that needs to be addressed. But a big shortage risk occurs when there are only a small number of companies that make a drug, and any one problem in one of those companies can take down a chunk of the market. Most drugs in shortage now are generics, meaning they are no longer protected by patents and can be made by any manufacturer. But even though generics can be made by anyone, most have very little competition. In the U.S., 40% of generic drugs are made by one single company makes the drug. So, Mr. Cockle, you represent the nonprofit drug manufacturer Civica RX. So you understand the economics of the generic drug industry. Why is there so little competition for such a high number of generic drugs?
Thank you, Senator. Typically, when a drug goes off patent and companies can bring generics to market, a lot of companies compete to bring that product to market.
And that was the model we all thought would happen.
Right.
But
unfortunately, what happens is when you have purchaser consolidation, contracting consolidation, drives that price down, concentrates the market share, and so the price goes so low that other companies may not have market share and may not have much incentive to stay in the market.
okay, so my understanding that part of the problem here is that it is expensive to run a drug manufacturing facility. But as you're saying, the margin for many of these generic drugs is so low that domestic manufacturers just aren't interested in making them. And as a result, we've become more reliant on foreign manufacturers to furnish some of our most basic and essential medicines. This obviously not only raises quality concerns, but it also poses a risk to our national security. So I was glad to see the Biden-Harris administration announce that it is expanding HHS's authority under the Defense Production Act to bolster domestic manufacturing of essential medicines, and that it will invest $35 million in U.S. manufacturing of key starting materials for pharmaceutical products. Now, Mr. Cockle, will investments in the manufacturing of key starting materials, that's a good thing, but will it be enough to alleviate drug shortages, or do we also need to think about investments in manufacturing finished drugs as well?
Yeah, thank you, Senator. I agree that it's a good thing to invest in key starting materials, but if we're focused on shortages, the key starting materials, the precursors even upstream of API are way, way upstream and not usually the thing that's causing the shortage. Most of the shortages are caused at the level of manufacturing the finished dosage form, the vial or the syringe of drug.
All right, that's a really important point, and I appreciate your making it. To prevent drug shortages, the Biden administration, I think, should build on these commitments to also invest in the manufacture of finished drug products. And it is important that the administration ensures that taxpayers get something for these investments. For example, by negotiating contract terms that the drugs will be made available to government programs and patients at a fair price if we're going to put taxpayer dollars into this. But I'm concerned that even this won't be enough to fully address the market failures in the generic drug industry. So one more question, Mr. Cockle. Are there generic drugs at high risk of shortage that are so unprofitable that Civica can't produce them but would be able to produce them if you had government assistance, a government contract to do it?
Senator, there are certainly drugs that at today's prices, any manufacturer, even a nonprofit, would be selling at a negative margin. And as you can imagine, even as a nonprofit, you can't sell very many drugs at nonprofit and at a negative margin and continue to operate. So yes, the answer to your question is yes.
All right. So I think it's important to acknowledge that the market alone won't fix this problem. If there are drugs that are priced so low that even manufacturers that are dedicated to preventing shortages won't produce those drugs, then the government must step in. And that is why I am reintroducing the Affordable Drug Manufacturing Act to direct HHS to manufacture or sign contracts to manufacture generic drugs in cases where the market has failed. Public manufacturing presents a powerful opportunity to resolve drug shortages, to secure the pharmaceutical supply chain, and to ensure generic drugs are both accessible and affordable for patients. Thank you. Thank you, Mr. Chairman.
Thank you. Senator Cortez Masto.
Thank you, Mr. Chairman. And thank you to the panelists. Thank you, your written testimonies. I've listened to your testimonies today. Obviously, such an important topic. Let me jump right in here. And Dr. Hernandez, let me start with you because I think we all were concerned reading the Wall Street Journal report that patients' insurance plans are paying thousands of dollars a month for certain specialty drugs. And what we're seeing, and that's because health insurers and PBMs are marking up the prices they set with pharmacies. And you talked a little bit about that. I understand you have a report coming out, is that correct, on this very issue?
Yeah, we had a paper published this morning that looked at the top 50 generic drugs by Medicare spending and how much the main 6 party sponsors were paid for them. So we identified as many as 16 generic drugs that had markups of over 1,000%. As imatinib, which is a cancer drug, which is now available as generic, is one example. But another example, for instance, is aripiprazole, an antipsychotic drug, that the pill actually costs the pharmacy less than 17 cents, but PBMs were reimbursing them as high as $11 or $5 per tablet. While I think this is not a contributor to shortages, and I think that's an important point to make because these drugs are, we're talking about drugs reimbursed by Part D, so drugs used in the outpatient setting. I think this is also another symptom of how the way how we pay for generics doesn't work. Just as we fail to generate incentives for manufacturers to produce certain drugs, we're also somehow in the Part D side allowing intermediaries to unjustifiably increase the cost of certain generic drugs, which end up in seniors paying more for their medications. So I just would like to make that point that I think there are two different symptoms that show the current shortcomings of the way how we pay for generics, and both of them need reform. But I don't think PBMs, are at fault for shortages.
Right, and I think there's from what I'm hearing, there's several solutions. There's several things that we need to be doing. And Dr. Wazinka, I thank you as well, because I was looking at your written testimony. One of the things you highlighted in your testimony this morning, and I want you to touch a little bit more on, is this idea that CMS Pay for Performance program to shift hospitals' purchase decisions. You talk a little bit about this. Say under the proposed Pay for Performance program, hospitals would be scored on their behavior on two measures. Do they buy from a reliable manufacturer, and do they buffer their inventory? So if you would talk a little bit more about that, but I'm also curious what you talked about, the buffering of the inventory for small hospitals, because we have a lot of small hospitals in rural Nevada, and you seem to indicate that we've got to be careful when we're talking about that when it comes to small hospitals. So if you would, please elaborate.
Yeah, so one of the features of this Pay for Performance program is that it allows us to be grouping. The idea is to compare it how you do to your to your peer. And so I would not want Mayo Clinic to be compared to a small rural hospital. Okay. And in a program like this, when CMS then assigns payments at the end of the year, they would be able to sort of assign a different amount of money to the different tiers of hospitals. So there would be opportunity to buffer certain types of hospitals more. Now, going back to, the Pay for Performance program would reward what hospitals do. I wanted to sort of highlight one more piece that we want to be also thinking about what are the things that we're trying to prevent versus what happens in the shortage. A buffer really is a buffer is when there is a shortage, and how resilient is the supply chain. Mm-hmm. And so it's really important that we just don't think about just buffering. The reason why we're looking at reliability and buying reliably is because that's what drives manufacturing quality. And if we don't solve that problem, we will continue to have disruptions. Mm-hmm. And the question is, are our buffers enough? There's so much panic buying right now that goes on when there is a shortage. You would have to have really massive buffers for the market not to be reacting the way it is. So we really have to get at the root cause of it, which is the manufacturing quality. And for things that we can predict, such as natural disasters and whatnot, or geopolitical threats, that's where buffers really should be playing a role.
Fair enough. Thank you. I have a couple of other questions, but I know my time is almost up. We will submit those for the record. I thank you.
Thank you. So let me just make an observation before we close the hearing, and that is that there is an inadequate supply of many essential drugs. They are not particularly expensive. The cost-benefit ratios are pretty dramatic, and it's affecting the proper medical protocols for treating certain illnesses and diseases. In a nation that spends the most for health care on any way you want to judge it, where the profit margins are pretty high in the drug industry, and it's an area in which we see a continuous increase in the use of prescription drugs and the cost of prescription drugs, and yet those that are less expensive we find in short supply. So Senator Warren's absolutely right. The market's not working in this regard. So we have to figure out how do we affect the market. So there's a lot of different ways that we can take a look at that, but we must have the data. And I'm not yet impressed that we have the information necessary to make the type of judgments that we have to make. So I would just urge us to try to get as much information as possible. One area that I've worked on is the expiration date on drugs, making sure that we had the maximum amount of time in order to use the current supply. But I'd be interested in your observations as to the impact it has on traditionally underserved communities. I find that if you know how to manipulate the system or use the system, et cetera, you can usually get your hands on whatever you need to. But if you come from communities that don't have that type of access or that type of supplies, you're usually at the bottom of the ring. So I see you're shaking your head. Tell me a little bit about the impact on underserved communities, and as we look at solutions for supply of drugs, how we protect the communities that have been traditionally left behind.
So with retail drugs, it's going to, the impact is going to depend very much on where the product is carried. And I actually I haven't seen the data, but I would not be surprised if certain chains were able to get the product more readily than others. To some extent, it's because the way DEA assigns quota, you have to come in with a contract to the DA to say, I have a contract with this wholesaler or this distributor or this pharmacy chain. And so if the DA doesn't assign quota to that manufacturer, you're going to suddenly have potentially a gap. So that's sort of a part of this is sort of in which pharmacies this happens and to what extent, for example, independent pharmacies are able to get access. On the hospital side, I spoke very briefly about this. There is a lot of anecdotal evidence. I am actually doing a research study where we're hoping to actually document this, but there's a lot of anecdotal evidence, especially there's an organization called Angels for Change, where they try to actually help coordinate and find cancer products. And if you talk to them, they will tell you the incredible inequities that have resulted from this shortage, because it's the small, the clinics, the independent clinics, the small rural hospitals that really just can't get their hands on the product. What happens is if there's any signal of a shortage, those who have the means and have the buyers and will basically try to procure as much product as they can. And then there's so much less on the shelves. And everybody is nervous, so everybody tries to buffer. I sort of compare it to COVID and toilet paper, right? Initially, we were comfortable with maybe having 4 rolls of toilet paper before COVID, and then you're down to 12, and you've got to go shopping, right? But when everybody does this, we pull so much more of the product out of the shelves. And then not everybody has the same ability to get to the product.
So let me try to get to solutions here. We recognize that we want to reduce or eliminate as much as possible the lack of supply of essential medicines, particularly those that are less expensive. But there will always be some shortage. So how do we put in place a system, how can government put in place some protections and guardrails to avoid that inequity?
Yes, I'll let Alan speak as well, but just really quickly, if the government is going to be creating any type of a stockpile, a stockpile, there really needs to be an allocation mechanism in place. If you were to create a pediatric cancer drug stockpile, and that's there are now 1% of patients in among all cancer patients, that stockpile would be tiny. Why would we possibly think that letting the stockpile be used in a shortage would go to pediatric patients? So we really need to be thinking about, who can get it, who cannot get it otherwise, and really have these kinds of allocation mechanisms. Even historical allocation mechanisms would go a long way, rather than let somebody buy, 10 times that they normally buy, and then basically kind of buffer themselves, but leave others behind. So I think that would be my recommendation.
Mr. Kuckel?
Senator, we have some of the largest health systems in the country, our Civica members. But we also have small rural hospitals that have joined as onesies, and they pay exactly the same price for drugs from Civica. And when they commit to buy a certain volume of drug, we hold a physical reserve inventory sitting in a warehouse of about 6 months of that drug, and the hospital, regardless of the size, is going to get their committed volume. And so I think that's the kind of approach we need to think about as we move forward.
Well, first, on behalf of the committee, we thank all 4 of you for your testimony here today and for participating in this important debate as we try to figure out the best way to deal with a problem I think we've all recognized. For the information of the members and staff, questions for the record are due by 5 p.m. next Tuesday, December the 12th. And there being no further business, the committee will stand adjourned with our thanks.